Has it hit record?
I hit the button and yep, we're starting.
There we go. Recording has started. Lovely.
3 minutes 40 ago, in fact.
Lovely. So good morning. I'm James. I'm one of the ST5 registrars at Great Western. Today I'm going to be talking about a contemporary classic, which is orotracheal intubation in patients with potential cervical spine injuries, an indication for the Gum Elastic Bougie, which was published in Anaesthesia in 1993, which now qualifies as a classic, by Nolan and Wilson, who are at the RUH. So you can tell it's a contemporary classic because it's only 4 pages long. There's minimal need for kind of postgraduate level statistical analysis, and it's got nice endpoints. So essentially, patients with injuries to their cervical spine may need urgent intubation, and this intubation needs to be fairly swift, and we need to not exacerbate any damage that they may already have. And I suppose it's important to know that trauma patients who've got head injuries may also have cervical spine injuries, so they kind of end up being an intermingled group. And at the point that this paper was published, there were 2 schools of thought. So you could either do an awake blind nasal intubation, which I'm not sure I've ever seen in the context of a trauma patient, or you could do an oral intubation, which I think is considered a bit more traditional. So the difficulties that you encounter with these patients are that you have a neck that is held in a neutral position with someone doing manual inline stabilization. So you've taken off the collar and the blocks and you have an assistant holding their neck. It also accompanies generally an unfasted patient where a rapid sequence induction is indicated, and people still like to use cricoid pressure. So they kind of come in combination. You have a neck that's held still and you have cricoid pressure applied. So both of those things and the removal of a pillow mean that we have a patient who's in a position that you wouldn't elect to intubate them in if you're in a normal setting. So the questions that this study aimed to address were, does the kind of the view that you get on laryngoscopy deteriorate when you make your intubation harder? And that's not going to be a particularly surprising finding. But essentially, they asked, if you remove the pillow, stabilize them manually and apply cricoid pressure, is the view worse than if you had them in a perfect position? And also they compared the time taken to intubate with a bougie versus without a bougie.
Was that in that position or in both positions?
Just in the suboptimal pillow removed. So what they did was they got ethics approval. They recruited 157 patients. These are ASA 1 to 3 elective surgery patients who were already going to require intubation, and they excluded essentially pediatrics and those who actually needed a rapid sequence induction. And it was done between the 2 authors of the paper. So one at that point was a senior registrar, one was a consultant. So to start with, they placed their patient in an optimum position to intubate them. They induced anaesthesia, gave them a muscle relaxant, which was either succinylmethonium or VEC. They performed laryngoscopy with a MAC 3 blade, and then graded their view. If they needed to, they could apply external pressure to the larynx to try and get some manipulation to improve their view. And at that point, they then removed the laryngoscope, and then they randomized them. So they randomized them to either direct visual intubation or intubation over a bougie. At that point, they removed the pillow, had an assistant perform manual inline stabilization and applied cricoid pressure. And they then attempted to intubate them with either a size 9 tube for men or a size 8 for women, which I think is probably a millimetre larger than I would do in routine practice in theatres at least. So as a quick reminder, folks.
So the first view is without in optimal position.
Yeah.
Yeah.
So they're sort of to address those 2 questions. They've gone basically all 157 people. They get them in a perfect position, grade them, put them in the kind of trauma position, and grade that. and then half of them get
They
a
must love it
bougie.
when it's like, oh, it's a grade 4 starting point. Good.
Let's make it harder.
Are they sort of manipulating the patients to get their best view? Are they having a lot of, if they not optimally positioned, if they need to move them around a bit, is that all done before they randomise them, or is it best view you can get with what looks like optimal positioning, but not spending a lot of time?
I think it's the one you just said there. So they put them in what they think is going to be the best position routinely. They have a look, and then they go into the other one.
Yeah. And I think they get a little bit of time to try and get as good a view as they can, by doing basic things. So as a quick reminder, they described grade 1 as being able to see some of the glottis, grade 2 the aretinoids, grade 3 just seeing the epiglottis, and grade 4 seeing neither the glottis nor the epiglottis. So that's a picture of how that intubation would look. So I think that all looks fairly awkward. It doesn't look very ergonomically pleasing. It might have been done specifically for the camera, I suppose, but you've got an intubating anaesthetist who's hunched over someone else who's doing the manual inline stabilization, and I'd frequently get them facing the other way. I'd get them facing towards me.
I've never seen it that way.
No, neither have I, but that's the photo that accompanied the article.
You get a lot of elbows in the face.
I think so.
Pretty into the ODP.
Yeah.
It's a very stooped position for an anaesthetist. I wouldn't think that it's very ergonomically pleasing for your back.
Yeah, it's not optimal anaesthetist position.
Not for your back, James.
I'm definitely not for my back. So they started a stopwatch when the anaesthetist took the laryngoscope from the ODP, and then they stopped the stopwatch when they had determined successful intubation with a wheeze esophageal detector. Has anyone ever heard of that before?
No.
Nope.
Sounds great though.
Can I get one?
So this must be a historical artifact now, because I think they've gone out of favour. But essentially, it's like a syringe add-on, and you're able to aspirate air out of it. I think the idea is that at some point, if you're in the esophagus, you wouldn't be able to aspirate any more air, but in someone's lungs, you can probably aspirate a fair bit of air. But then they further confirmed it with capnography and auscultation, and I think maybe our practice has changed, that we now prefer capnography as our first line confirmation of successful intubation. And there was some crossover between our groups, so if you started off in the visual group and then were unsuccessful after 2 attempts, you were permitted to use a bougie to bail yourself out. So they described their use of the bougie. So in a bougie group, you're either watching your bougie go through the chords, or you could do a blind kind of bougie where you would feel either the clicks as you go through the tracheal rings, or feel the rotation as you go down a main bronchus, or, and I've never put it down this far, hold up as you start pushing it into small bronchi. I don't think I've ever pushed it in that far.
I don't think I've pushed it far enough to know that I'm definitely down a bronchus. Even.
No.
That would
I'm usually
scare
happy
me.
with the clicks.
Yeah, I'm delighted with the clip.
Maybe you just pushed it through into the lung parenchyma if you're in a small bronch.
I mean, I just hope it's never that traumatic. So in terms of their results, they found that in their 157 patients, about half of them had the same view going from their optimized position to your sort of trauma position. About a third of them dropped 1 grade, and then about 10% dropped 2 grades. So that meant that essentially in a fifth of your patients, you got a grade 3 view, where actually only 1% had that in their optimized position. So it looks like it might be a fantastic way of converting a very easy, straightforward intubation into a potentially fairly tricky one. And that's the table representation of it. So what you can see is essentially a shift from being mostly grade 1s to shifted along I think the more worrying part really is that there are quite a lot of grade 3 views where before there weren't. It looks like they didn't get any grade 4 views, which is encouraging. So the other question they asked was about time to intubation. So unsurprisingly, it was quicker to intubate just passing an endotracheal tube down as opposed to passing a bougie and then railroading a tube over it. And that saved you about 6 seconds.
It's not much, is it?
It's not. And then in 11 patients in the visual group, it took over 45 seconds. So essentially, it's usually quicker for an easy one to just directly intubate, but in the difficult patients, it's quite slow. And then they had 5 in the visual group that couldn't be intubated at all, and they had to use the bougie as a bailout technique. Whereas the patients in the bougie group all managed to get intubated on their first attempt. And there you can see basically the intubation times. So I think this is an interesting parallel for me and using video laryngoscopes. So for your easy intubations, it's a little bit faster, but not meaningfully faster to just directly intubate. But using a bougie seems to reliably get everyone into a kind of a narrower distribution of time taken to intubate, whether they are easy or hard. And if you just do direct intubation, you tend to get the easy ones are still very quick, but then the hard ones are very, very slow. I think that's analogous to your video laryngoscopes, where it's slightly slower to intubate a normal patient with a video laryngoscope, but then it's considerably quicker than direct laryngoscopy on your difficult airways. So repositioning your patient from your optimized position to your kind of trauma intubating position makes your view harder. Without a bougie, some patients couldn't be intubated at all and required a bougie as a bailout. And they observed, it was interesting that they were able to blindly intubate 8 patients just by prodding around with the endotracheal tube. So again, I wouldn't really suggest. So really the interesting points here are trying to just directly intubate these patients can take ages if they are difficult, and those are likely to be the patients where they are injured, potentially hypoxic, cardiovascularly unstable, and you probably don't want to compound their injury by giving them a period of hypoxia and hypercarbia. So the two things here that are sort of entwined are that this is looking at both your manual inline stabilization and the application of cricoid. We know that applying cricoid makes your life harder and your view worse anyway, so it's a little bit difficult to tell how much of it is the manual inline stabilization and how much of it's the cricoid, but they usually come as a parcel. What do you feel about how this applies to the age of video laryngoscopy? So I don't think
I'd go straight.
Yeah, I'll go straight to video, but I've got other issues with this paper. So
go for it.
You already instrumented the airway before you actually go and do second one, so you already got more edema, actually making it more difficult. Secondly, I don't know what experience in sucks, but they haven't told you what the dosing of sucks they gave the patient is. So in my experience, if sucks can wear off pretty quickly. I mean, we often actually, especially, I mean, maybe not in 1993, but nowadays you're probably underdosing by giving a biotic to a lot of patients. So you could have a patient becoming not quite as paralysed as you think they are when you're going for your second year. That's also making it more difficult to intubate the patient. So you've got those other considerations as well, on top of like the cricoid and nails and the
Absolutely. I don't think they didn't quantify the amount of time it took, but if you imagine if you're waiting for your optimum intubating conditions, performing laryngoscopy,
randomized,
taking out the laryngoscope, changing their position, getting your Mills cricoid on, randomizing them.
Yeah.
I mean, what? That could take a couple of minutes, by which point you go from potentially just after the peak of your optimum intubating conditions to, they're not quite relaxed. So maybe that's maybe that's different in the age of rocuronium, where maybe we're giving something that's going to keep them relaxed for minutes and possibly tens of minutes and maybe an hour. I suppose it's difficult in the age of video laryngoscopy to talk about whether or not you're on a bougie. My practice is to always use a bougie when I'm downstairs. I find that I need a kind of a less direct view, if that makes sense, a less direct path.
Can I just ask about the availability downstairs of CMAX? Do they have one in
they have one. It's not in the world of COVID, it's not routinely brought in, but if you want it to be, then it will be. So I think it's probably one of those things that you could have very quickly available to you, and you could draw up everything, and then at the last minute you could go on if you needed to, or you could have there's loads of people there, so you could always have a one that grabs and grabs it.
Yeah, it's kept in that little donning area.
Okay.
Alongside like the ventilator and the transport monitor and the bridge to put on the bed.
You have to go down to the
No, I might get one of you. Sorry.
We can.
This morning we can wander down.
We can wander down.
Sorry.
It's very useful to have.
Yeah.
I think I use it in every intubation I do in resus. I can't see a good reason to not use it.
Argument in those situations.
So the other bits to discuss were, so this contemporary classic was prompted by the Association of Anaesthetics doing a kind of an opinion piece, basically saying, is it time for us to start abandoning something like Mills? So the history behind it is quite interesting. So essentially it got imported with ATLS from America. There is precious little evidence behind it. In fact, what little evidence there is suggests that it's harmful. So it does the things to our airway that I've described. So it makes our intubation harder. It makes the time to intubation longer in patients who may not enjoy an extra period of hypoxia and hypercarbia. And then there are suggestions that we accidentally increase the forces that we transmit to their C-spine by having someone hold it still. So it seems to be a piece of kind of dogmatic practice that doesn't necessarily have an evidence base, that's kind of crept in and become enshrined and is now stuck, and it sits inside NICE guidelines as a standard part of your care that should be performed. A lot like cricoid, which is, funnily enough, one of the things that I was going to force on you guys after this chat. So there's a really good talk by Dr. Hines called Cricolol, which I will get you all to watch afterwards, which essentially, if you're trying to market cricoid pressure as a drug, you would probably never approve it for use, and you'd also never actually use it in clinical practice.
Yeah, also available as a suppository, because for all the good it does, you might as well shut it up.
You have seen it then, yeah. So yeah, there's a question about actually maybe both cricoid and Mills are useful in the correct set of patients. So perhaps in someone who's got a full stomach who is regurgitating, cricoid is going to be useful there, but maybe in the majority of sort of lower risk patients, actually you're probably causing yourself difficulty in them harm, and potentially the same for Mills.
And you can change your mind about cricoid, because obviously if you can't get a good view, your priority is securing the airway, and actually you shouldn't just stick with cricoid for the sake of sticking with
in the same way,
cricoid.
in that way. I just said like, if there's a views bad, just immediately take just for that airway.
I find the Mills, the biggest difference is the person doing Mills. So like for those of you or those that are going to be doing neuro, what they tend to do in trauma centres is they get the surgeons to do it. And when you actually see the surgeons do, the spinal surgeons, they move their head around way more than you think you normally would do. So if you leave them in charge of it, then they let you have much more than you normally would do, and they're happy with that, and they deal with it the whole time. So
yeah.
If I have a spinal surgeon or done a scene ortho, then I just get them to do the Mills.
Shove them down in your crotch, so you can scratch over them.
No, I don't do that.
But it's a fascinating difference, because we think tiny little movements are awful, and we do I've done like incredibly careful intubations and then handed it over to a neurosurgeon, and they're the ones who've seen the patient, they've assessed that they have an unstable C-spine, and then they are moving them really quite a lot, and they are very happy with it. I guess.
So I was going to ask a question.
Familiarity.
Potentially, sort of, you've answered in that of you guys who've done more stuff in trauma centres, if we say video laryngoscopy probably is what most of us would do, would you automatically go straight for something like a D blade so you can absolutely minimise the amount you might have to extend the neck, or would you just, but with a caveat that that's going to probably make your intubation less easy, or would you just, as you're alluding to, accept that a little bit of movement is probably not the end of the world, and securing the airway faster and in a more straightforward fashion with a non-air blade is better?
So I'd be interested to hear what you guys do, but quite frequently I find that a D blade gives me a beautiful view on a screen, but then a very difficult intubation that takes me longer. So my preference is for using kind of a Mach 4. So they use a Mach 3 for direct laryngoscopy here, and actually, yeah, quite often for men I'd use a 4. So I'd use kind of a CMAC 4 blade, and then if I was struggling, maybe switch to a D blade.
Yeah. And if I was using a D blade, so what I would do is, if I think they're going to be difficult, it doesn't happen so often now because there's less people who are actually collared, or they just come in blocks, so it's a bit easier. But if they're in a collar, then I have to think they're more difficult, and then I'll make sure I've got a D blade. The last one, D blade. And if I'm thinking I'm going to have to D blade, then I often will use a stylet. It's one of the few times I would kind of routinely grab for a stylet.
I've never actually used a stylet, but
because they're much more fixed.
Yeah. It's basically preforming the bougie.
Yeah, I mean, you can try and preform the bougie and do the kind of like snail and all the other stuff, but actually, what you'll find is if it's a beautiful view and you're struggling to get around, you'll still kind of struggle with the.
It's that bit where you have to sort of rotate. You've got so much angulation that you're directly upwards, aren't you? So
yeah, exactly. So it's something I wouldn't routinely. I'd rather go for something I'm more used to using, like a 4 blade, and then if I really need to, then I'll use the bougie. Sorry, the D blade.
Yeah, I think it's.
I completely agree. I think it gives you a great view of the D blade, but it wouldn't be my go-to because for most people it will complicate it.
Yeah.
I guess that fits what you're saying, that actually a bit of movement is probably not the end of the world. So
I think watching the surgeons, the key seems to be keeping everything straight. So I think being slightly less worried about sort of flexing, extending, but you certainly don't want it kind of like going across.
Rotating.
So I think as long as you can keep them straight, even if you allow the anaesthetist to kind of pull the head up a bit, you're kind of bringing the body with it, but it doesn't seem to matter quite as much.
So I think if you're using a D blade, always use a stylet, because you will never for the life of you get a normal tube around such a kind of hyper-angulated shape. And
if you do get bougie, you probably would be fine using a 4 blade.
Yeah, if you get and yeah, it's I suppose it's about doing what's safest for the patient, and if that is briefly removing these things that may not have much evidence behind them to safely intubate them, that's probably less harm than keeping those things on and then turning them into a difficult airway disaster. Because front of neck access is likely to be very traumatic to their C-spine. Yeah, hyperextending their neck and then doing an awful lot of pressing is probably quite bad news for them. Cool. Is there anything else that we'd like to discuss or go through? No.
Thank you.
Do you have anything, Kartik?
No, it's all very interesting. All very new.
It's a contemporary classic. Kartik, what year were you born?
After this contemporary classic was published.
Oh my!
Wow.
It's actually an old paper. Some would argue it's ancient.
So this is one of the things that absolutely fascinates me, is that we don't have to go that far back for interesting published literature to fit on 4 sheets of paper and to be like an interesting published article. Like this is 2 people just doing something to the patients that they were electively intubating and managed to like publish a paper that then becomes a classic. Whereas if you look at things that get published now, they are multi-center, RCT, complex statistical analysis.
I'd be really interested to
That's
see
probably a piece of
like, if we
robust-
could get ethics approval for this, like nowadays.
Yeah, it'd be interesting.
I'd be curious as to whether they'd be like, yeah, it's fine, go for it, or there'd be a lot of.
I don't think you'd have 150 willing volunteers to let you intubate them and then re-intubate them again. Just, I think it's all about framing. I think you'd struggle if you actually adequately consented the patients and explained the risks, benefits, etc. I think you'd struggle to get.
We're gonna stop you breathing. Have a look in the back of your mouth. Then we're gonna move you around to make it harder.
Yeah.
And then we're gonna see if we can get the tube in.
And I'm going to increase your risk of dental damage and.
Increase your risk of adverse outcomes.
Yeah.
We're expecting that it's going to make it harder.
Yeah, and then
For our own balance,
Benefitation.
then
That's how I feel about it.
and especially when you look at
it's hard no from them.
and when you look at their time to intubation, there is a small peak at 95 seconds. So that's spending over a minute and a half trying to directly intubate a patient.
That's the brown trouser. So.
Well, I mean, if you're trying to put a tube in a grade 3 view without anything, like, that's got to be quite difficult, isn't it?
But for science, they tried.
Surely you must be quite worried at that point. You're just like bludgeoning the larynx, and
Well, if you can't see, you can't see the damage.
yeah, that would worry me.
All right. So, Kartik, you have.
Out of curiosity, sorry, just one thing that kind of came into my head then. So if Mills seems to be harmful, is it being phased out, or is it still? I mean, I know it's still like practice as it stands, and I think if you didn't do Mills, people would look at you quite funny. But is it being like recognized that it is a potentially harmful practice, or is that still very, very new?
So the article that I've linked in this discussion, which I can share the screen for, is from the Association of Anaesthetists. And it's an opinion piece, which is essentially saying we should be considering stopping using it. But it's a little bit like cricoid pressure, where we've known for quite a while that cricoid pressure is potentially a fairly harmful thing to do, but because it's entrenched in our practice.
And that the evidence is very weak that actually helps.
I think you'd be criticised a lot more for abandoning manual inline stabilisation than you would be for cricoid. I think I haven't worked in other places, but like Australasia, Europe don't use cricoid. Like,
is it an ET? So, is Mills an ETC?
I don't know. I haven't done ECT, I'm afraid. But I imagine that I think Mills is more worldwide than cricoid is.
Do you know, I think a really important element of it is actually that visual reminder. Almost more than what it's actually doing. It's just reminding everyone we need to be careful with this C-spine, even if you're not absolutely immobilising. I think it's quite an important visual reminder.
Jules Blackham, the ED, he's very good to talk about spinal precautions and the harms that come with them. And he basically is very much along those lines. It's really all it's there for is to remind people not to flap somebody's neck around. And the more you try and force it, the worse everything becomes. Basically, he's more. I mean, he's like his big mantra is not putting collars on. And stuff like
so
that,
he's having blocks and trying to make them as comfortable as possible. His big bit of work was in like awake patients and this kind of concept that everyone can come in collars and blocks and stuff when they're awake. And he's like, if you're awake, then you either protect your own C-spine or you don't have a C-spine injury, and that you do a lot more damage by trying to restrain these patients. But yeah, that kind of fits all the way through, really, doesn't it? Only a very small proportion are ever going to have an injury in the first place, and if you make other aspects of their care suboptimal, it's definitely a trade-off.
Cool.
Should we stop it there then?
I'm going to stop recording then. Thank you very much, James.